Hi, welcome back. Okay, we were discussing the lower limb. We are almost done with the lower limb. Let's wrap up this lower limb by finishing off this the sciatic nerve. So let us talk about the sciatic nerve now. Now we are done with the thigh, the foot, and all muscles in the foot and all. So we can talk about the sciatic nerve. It's better if you take a fresh page for this. Now, thing about sciatic nerve is, guys, sciatic nerve is the main nerve of the lower limb. We only have the anterior compartment and the medial compartment which are supplied by the femoral nerve and obturator nerve. Now, we still have to supply the posterior compartment of thigh. We still have to supply all the three compartments of the leg, and we have to supply all the muscles in the foot, which we are already done with. That's a branch of tibial nerve, lateral and medial plantar nerves. So, sciatic nerve, first of all, the first thing is that how does it leave the gluteal region? See, sciatic nerve will not supply anything in the gluteal region. Now let's say this line here represents the region above is the gluteal region here. It is gluteal region. Then we'll have the posterior compartment of thigh. Let's say this is posterior compartment of thigh. Then we have popliteal fossa here. Let's say this is popliteal fossa. And then we have in continuation with the posterior compartment of leg, and finally the foot. So this is leg, and let's say this is foot. So this is how we're dividing the region. This is how you should divide the page, so that we can talk about the sciatic nerve in these region. Gluteal region, no branches in the gluteal region as I said. So then posterior compartment of thigh, leg, popliteal fossa, and continuing with the posterior compartment of leg and the foot. The sciatic nerve usually it passes deep to this muscle called as piriformis. Now there is a muscle present here that is called as piriformis muscle. As I said, sciatic nerve usually passes deep to piriformis. Sometimes it pierces piriformis as well, but in most of the cases it goes deep to piriformis. So it passes deep to piriformis, comes into the posterior compartment of thigh, that is hamstring compartment, and then in the upper part of the popliteal fossa it divides into tibial nerve, which will continue straight, and common peroneal nerve, which will go to the neck of the fibula. So first let's talk about this nerve here. In the posterior compartment of thigh, the sciatic nerve will supply all hamstring muscle. Now I am writing semitendinosus, semimembranosus, biceps femoris. Only what head I'm writing here? I'm writing here the long head, and adductor magnus, that is hamstring part. Now all these muscles are supplied by semitendinosus, semimembranosus, biceps femoris, long head, and adductor magnus, hamstring part. They are all supplied by the tibial component of sciatic nerve. Now sciatic nerve is having tibial component and common peroneal component. This is supplied by the tibial component. In other words, let's say if there is a higher division of sciatic nerve, if sciatic nerve divides into common peroneal nerve and tibial nerve here in the iliac region only, or somewhere in the gluteal region only, then these muscles will be supplied by the tibial nerve, and common peroneal nerve will supply only short head of biceps femoris. Short head of biceps femoris is supplied by the common peroneal component. By the common peroneal component. As we say, the nerve now divides into tibial. This is the tibial nerve. And there we have common peroneal nerve. Tibial and common peroneal nerve. The tibial nerve supplies the posterior compartment of the leg. Now the muscles which are supplied by the tibial nerve includes the superficial and deep muscles of the calf. So it supplies muscles like popliteus, plantaris, gastrocnemius, soleus. It supplies one muscle in the popliteal fossa, muscle in the floor of the popliteal fossa, that is popliteus. Then these three superficial muscles, that is plantaris, gastrocnemius and soleus, and also the deep muscles, which are tibialis posterior and flexors. Posterior compartment or calf is a flexor compartment, so flexor hallucis longus, flexor digitorum longus. So it supplies tibialis posterior, flexor hallucis longus and flexor digitorum longus. And then this tibial nerve passes deep to the flexor retinaculum, which will be somewhere here. This is flexor retinaculum. And we already know it divides into medial plantar nerve and lateral plantar nerve, which we don't have to talk about. We already know what are they supplied by: medial plantar nerve and lateral plantar nerve in the foot. So tibial nerve supplies popliteus, plantaris, gastrocnemius, soleus. These three are the superficial muscles here. And soleus tibialis posterior, flexor hallucis longus, flexor digitorum longus. Flexor compartment. Posterior compartment of calf is a flexor compartment supplied by the tibial nerve. Now as I said, common peroneal nerve, this common peroneal nerve will reach the level of neck of fibula. Coming to this one here. If this is the neck of fibula, it's the level of the neck of fibula, the usual site of injury to the common peroneal nerve, that is neck of fibula. The common peroneal nerve divides into superficial peroneal nerve and deep peroneal nerve. Now let's say this is here superficial peroneal nerve. I am writing SPN, superficial peroneal nerve, and that is deep peroneal nerve, DPN. Common peroneal dividing into superficial peroneal and deep peroneal. Superficial peroneal nerve is the nerve of the lateral compartment of leg, which is having everters like peroneus longus and peroneus brevis. Peroneus longus and peroneus brevis. And then it will go into the foot and supplies the skin over there, which I'll write separately. I'm just making a star here. It will supply some skin, which I'll write here. Superficial peroneal nerve supplies the skin of dorsum of foot, except, this is important, except first web space, because the first web space actually will be supplied by the deep peroneal nerve when it come into the foot, except first web space, which is supplied by deep peroneal nerve with the dermatome of L5. So first web space is an important dermatome to remember. First web space of the foot is supplied by the deep peroneal nerve with the dermatome of L5, and rest of the dorsum of foot is supplied by superficial peroneal nerve after it supplies peroneus longus and brevis. Now we saw these are the muscles of posterior compartment, these are the muscles of lateral compartment. What is left is muscles of anterior compartment, and deep peroneal nerve supplies muscles of anterior compartment, namely tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus tertius. This muscle is peroneus tertius. Tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. Peroneus tertius. Now it also supplies one muscle in the dorsum of foot. We usually see there are no muscle in the dorsum of hand. We only have the tendons in the dorsum of hand. But we do have a muscle in the dorsum of foot, and the only muscle in the dorsum of foot is extensor digitorum brevis, supplied by the deep peroneal nerve in the foot. The only muscle present in the dorsum of foot is extensor digitorum brevis. Extensor digitorum brevis. And you already know what it is supplying. It is supplying the first web space. After that, it supplies the skin of the first web space. So this is about the sciatic nerve and its branches. Now look at this, guys. Tibialis posterior and tibialis anterior. These two muscles are supplied by different nerve. Tibialis posterior is by tibial nerve, and tibialis anterior is by deep peroneal nerve. Whereas peroneus longus and brevis is supplied by the same nerve only. Now why I am telling you this, because for the inversion of the foot, we need tibial nerve, we as well as we need the deep peroneal nerve. So if the question says that because of some injury there is a person is unable to evert her foot, if the person is not able to evert her foot or his or her foot, then that is because of the injury to the eversion is by peroneus longus and peroneus brevis. So that is by superficial peroneal nerve. So injury to superficial peroneal nerve, there is loss of eversion. But loss of inversion will be when the injury is to both tibial nerve as well as deep peroneal nerve, because these are the two muscles for the inversion. So injury to deep peroneal and injury to tibial, when it happens to both the nerve, then only there will be loss of inversion of foot. If you are writing, I say it again, injury to superficial peroneal nerve, that is loss of eversion of foot. Injury to tibial nerve and deep peroneal nerve, loss of inversion of foot. Loss of inversion of foot. So this is about the sciatic nerve. This is all about the lower limb. Let us now switch to the last topic, or last unit of the gross anatomy as such, that is abdomen and pelvis. So let's begin the abdomen with the abdominal wall. We will talk about the abdominal wall first, and in this first session of the abdomen, we will talk about the abdominal wall, and we will take the most important topic of the abdomen first, that is perineum. We will talk about the perineum, what are the perineum, perineal pouches, diaphragm and everything, and the next session we will talk about rest of the abdominal viscera and other things. Okay, so let's start with abdomen here. And we are starting with the anterior abdominal wall. Now let's say this is xiphoid process and these are costal margins. There is iliac bone and there we have umbilicus. Guys, umbilicus is the watershed area for the anterior abdominal wall. I am writing U for the umbilicus here. It is the watershed area because the blood vessels, see, lymphatic drainage, first of all the lymphatic drainage from above the umbilicus goes into the axillary lymph nodes, whereas below the umbilicus the lymphatic will go into superficial inguinal lymph node. Superficial inguinal lymph node. Similarly, blood supply, the artery supplying anterior abdominal wall above the umbilicus and below umbilicus, and the venous drainage from above the umbilicus and below it is by superior epigastric vessels, and by below is by the inferior epigastric vessels. Superior epigastric vessels and inferior epigastric vessels. So it is a watershed area, the umbilicus. You can see the lymphatic drainage above the umbilicus into axillary lymph nodes and below into the superficial inguinal, and superior epigastric vessels and inferior epigastric vessels are taking care of the anterior abdominal wall above and below the umbilical opening. Layers of anterior abdominal wall. If you go about the layers of anterior abdominal wall from superficial to deep, then it goes like skin, superficial fascia, which is actually having two layers. We have Camper's fascia first, followed by Scarpa's fascia, number 3 Scarpa's fascia, Camper's fascia, Scarpa's fascia. Muscles, external oblique muscle, internal oblique, transverse abdominis, and behind this we have fascia transversalis. Behind fascia transversalis is extraperitoneal connective tissue, CT is for connective tissue, and then we'll reach the parietal peritoneum. So to reach the peritoneal cavity, guys, these are the layers we have to go through. Skin, Camper's fascia, Scarpa's fascia, external oblique, internal oblique, transverse abdominis, fascia transversalis, extraperitoneal connective tissue, and parietal peritoneum. These are the layers of anterior abdominal wall from superficial to deep. So from the superficial to reach the peritoneal cavity, these are the layers we need to excise. Let us talk about the modification of the anterior abdominal wall, especially the modification of this muscle, that is external oblique muscle. The modification of the external oblique aponeurosis will be inguinal ligament. So the modification of this muscle or the aponeurosis of this muscle will form the inguinal ligament, which is our next topic. So let's talk about the inguinal ligament and further modifications of inguinal ligament, so that after that we can talk about the rectus sheath and inguinal canal. Okay. Inguinal ligament. The first thing is, guys, the inguinal ligament is the modification of, it's the modification of external oblique aponeurosis. It's a modification of external oblique aponeurosis. Now, as we already said, if this is the ASIS, anterior superior iliac spine, and this is pubic tubercle here. So this is the inguinal ligament stretching between ASIS to pubic tubercle. The modification of this inguinal ligament R, now this is inguinal ligament as I said, modification of inguinal ligament R, there is a ligament which is running along the superior ramus of the pubis called as pectineal ligament. So one modification is pectineal ligament. It is running on the pectinate line, so we call it pectineal line, so we call it pectineal ligament along the superior ramus of the pubis. Another modification of inguinal ligament is this triangular ligament stretching between the pectineal ligament and rest of the inguinal called as lacunar ligament. You guys talk about this lacunar ligament mainly during the femoral hernia surgery. Sometimes accessory obturator artery is present along the lacunar ligament, and any wrong incision to that accessory obturator artery can lead to the alarming hemorrhage. So pectineal ligament 1, lacunar ligament 2, and there is another modification that is called as reflected part of inguinal ligament. This is called as the reflected part of inguinal ligament, which is going and attached to the linea alba. I'm sure you know what is linea alba. It's a midline of the abdomen. This is linea alba, and this is a third modification we are talking about. This is nothing but the reflected part of inguinal ligament. That's the third modification. So guys, these are the three modifications of the inguinal ligament. Inguinal ligament itself is a modification. It's a modification of external oblique aponeurosis, and now we have modification of the inguinal ligament, that is pectineal ligament, lacunar ligament, and the reflected part of inguinal ligament. We need to know about these modifications before we talk about the inguinal canal. Knowing about these ligaments and these modifications, that is pectineal, lacunar, and reflected part, now we are in position to talk about the inguinal canal and its boundaries. So let's talk about the inguinal canal and its boundaries. Okay. Now inguinal canal is actually stretching between, if this is once again the inguinal ligament here, the inguinal canal is stretching between the superficial inguinal ring and deep inguinal ring. Now the superficial inguinal ring is somewhat like this. We have a superficial inguinal ring, and there is a deep inguinal ring, and that is inguinal canal. Superficial inguinal ring and deep inguinal ring. Now superficial inguinal ring is an aperture which is present in the external oblique aponeurosis, whereas deep inguinal ring is an aperture present in fascia transversalis. Important thing about this obviously is inguinal canal. This is inguinal canal. The important thing about the relations of inguinal canal is that what are the structures related anterior or posterior to inguinal canal toward the medial side and toward the lateral side. Common relation, we know that what is anterior and what is posterior, but what is important is to know that what are the structures forming anterior relation or the anterior wall of inguinal canal only toward the lateral side, or posterior relation or posterior wall of inguinal canal only toward the medial side. So this difference is important, and for that we will take a transverse section. If we take a transverse section of the abdominal cavity in the lower part from the level of inguinal canal only, this is how it goes. So there is fascia transversalis here, this is fascia transversalis, and in the fascia transversalis we have deep inguinal ring. Whereas this is external oblique aponeurosis in which here we have superficial inguinal ring. So this is deep inguinal ring, and that is superficial inguinal ring. Superficial inguinal ring, as we already said, this is an external oblique aponeurosis, and that has to be in the fascia transversalis. And stretching between the two rings is the inguinal canal. So there we have this inguinal canal. So let's say it is a transverse section. Make sure you write it somewhere. It's a transverse section. Anterior wall. To understand this anterior and posterior wall relation, special difference on the medial and lateral side, let me limit this first. Now let's say this line here is from the lateral margin of deep inguinal ring, and this line here is from the medial margin of superficial inguinal ring. Anterior wall of the inguinal canal, anterior wall of inguinal canal in the entire extent, is by this aponeurosis, that is external oblique aponeurosis. So this is there. So this is anterior wall, obviously that is posterior wall. So anterior wall in the entire extent is by external oblique aponeurosis, but anterior wall only toward the lateral side. Laterally it is also by, obviously there is external oblique aponeurosis, but there is also this internal oblique muscle. Transverse abdominis is not forming the anterior wall, remember that. This is internal oblique and that is transverse abdominis. So laterally we only have internal oblique muscle, but not transverse abdominis. So anterior wall in the entire extent is by external oblique aponeurosis, and more toward the lateral side it is also by internal oblique but not by transverse abdominis. Similarly, posterior wall in the entire extent is by fascia transversalis, as you can see that is by fascia transversalis. But medially it is also by a tendon which is formed by the transverse abdominis and internal oblique on that side or behind the inguinal canal, called as conjoint tendon. So there is a tendon over there, that is conjoint tendon, and that one modification of inguinal ligament we just discussed called as reflected part of inguinal ligament. This is conjoint tendon, and that is reflected part of inguinal ligament. So posterior wall, as I said, is by the conjoint tendon, also by the conjoint tendon. Fascia transversalis is there in the entire extent, also by the conjoint tendon and reflected part of inguinal ligament. Reflected part of inguinal ligament. Zoom out रखो उस पे भी. This is about the anterior and the posterior wall and their difference toward the medial side and the lateral side. Now what is forming the roof and the floor of the inguinal canal? To understand the roof and the floor of the inguinal canal, we will take a sagittal section here. Now if let's say there is a sagittal section, it's a parasagittal section basically, and taken from the inguinal canal, and let's say this is the inguinal canal here. This is how external oblique aponeurosis will come and will form the inguinal ligament which forms the floor. This is, let's say this is pubic bone here. So this is external oblique aponeurosis which is forming the anterior wall. Anterior wall we already saw is also found by the muscle that is internal oblique muscle. This is internal oblique. But transverse abdominis is not forming the anterior wall, so I'm not taking it to the anterior side, but yes, it is present in the roof, and yes, it is joining with the internal oblique to form that conjoint tendon behind. See, roof is formed by these two things here. So roof of the inguinal canal is by the arched fibers. This is by the arched fibers of internal oblique and transverse abdominis. By the arched fibers of internal oblique and transverse abdominis. This is conjoint tendon, we don't have to talk about it. We saw the conjoint tendon is forming the posterior wall. We already know anterior wall is by external oblique aponeurosis and by internal oblique. Floor of the inguinal canal in the entire extent is by inguinal ligament, and it is also by the modification of inguinal ligament toward the medial side, that is lacunar ligament. So lacunar ligament medially is forming the floor of the inguinal canal. So guys, this is the anterior wall, posterior wall, roof, and the floor of the inguinal canal. Anterior wall, posterior wall, roof, and the floor of inguinal canal. Coming to the contents, there are two types of content, the true and the false content. In case of male, the content is spermatic cord and ilioinguinal nerve, whereas in case of females, it is round ligament of uterus and once again ilioinguinal nerve. Round ligament of uterus and ilioinguinal nerve. So contains spermatic cord and ilioinguinal nerve, and in case of female, that is round ligament of uterus and ilioinguinal nerve. Now, spermatic cord and round ligament of uterus, these are the two contents, but ilioinguinal nerve is actually a modified content, or it's a pseudo content. Why? Or it's a false content. Now coming to this thing here, the true contents are those which will enter through the deep inguinal ring and will come out through the superficial inguinal ring. That's why we call it true content, and that is about the spermatic cord and round ligament. These are entering like this, but ilioinguinal nerve actually enters by piercing the posterior wall of the inguinal canal, and then it comes out of the superficial inguinal ring. This is about ilioinguinal nerve, and that's why it is a pseudo content, or it is a false content of inguinal canal, because it pierces the posterior wall to come inside. It didn't enter through the deep inguinal ring. So this is about the inguinal canal. Let us also talk about the rectus sheath, and then we will go to that one major topic of the abdomen, that is perineum. So first, let me finish off this by doing the rectus sheath. Guys, to understand the rectus sheath, we have to take sections of the abdominal wall at three levels. Now once again, this is xiphoid and this is costal margin. So first we'll take a section here above the costal margin. then we'll take a section below the costal margin but above the arcuate line, and then we'll take a section below the arcuate line. First of all, what is arcuate line, guys? Arcuate line is the lower limit of the posterior wall of rectus sheath. Arcuate line is the lower limit or lower border of posterior wall of rectus sheath. So posterior wall of rectus sheath, this is anterior wall and posterior wall, they will come like this. Anterior wall will continue, but posterior wall will randomly finish at one point. So that lower margin of the posterior wall of rectus sheath is called as arcuate line. So guys, our sections are, we take a section above the costal margin, this section is between costal margin and arcuate line, and this section is below arcuate line. So we need to consider these three sections. So when we take a section above the costal margin, if you take a section above the costal margin, then the only muscle you can appreciate here in the abdomen is either rectus abdominis or external oblique muscle. You cannot appreciate internal oblique and transverse abdominis. Now if this is the rectus abdominis muscle here in the transverse section, this is rectus abdominis. And there we have external oblique on the side. So this external oblique aponeurosis is actually passing only anterior to rectus abdominis muscle, forming the anterior wall of the rectus sheath. This is external oblique muscle. This is rectus abdominis, which we'll keep drawing again and again. So anterior wall of the rectus sheath, the anterior wall is by the external oblique aponeurosis. That is anterior wall of rectus sheath above the costal margin. Posterior wall of the rectus sheath above the costal margin is only made up of costal cartilages and nothing else. Costal cartilages are the one which are forming the posterior wall or posterior margin. That is about the first section, guys, when the section is taken above the costal margin. If the section is taken between the costal margin and arcuate line, then all the muscles on the side are seen. So we will appreciate rectus abdominis muscle. Once again, this is rectus abdominis here, and we have all the three muscles here, that is external oblique, internal oblique and transverse abdominis. So we have all the three muscles to be seen here. I said external oblique, internal oblique, transverse abdominis, and that obviously is rectus abdominis. At this time, external oblique aponeurosis will pass once again anterior to it, whereas internal oblique aponeurosis will split up to form the anterior lamina and posterior lamina to enclose the sheath here. Internal oblique aponeurosis will form the anterior lamina and posterior lamina to enclose this rectus abdominis muscle, and transverse abdominis aponeurosis is simply passing posterior to it. What else we have here is the fascia transversalis. So guys, this is the anterior wall of rectus sheath now, and here this is the posterior wall of the rectus sheath. You can clearly see that anterior wall of the rectus sheath is made up of, once again, external oblique aponeurosis plus anterior lamina of internal oblique aponeurosis. On the other hand, posterior wall of the rectus sheath, this is about anterior wall, posterior wall of the rectus sheath is by posterior wall of internal oblique aponeurosis transverse abdominis aponeurosis and fascia transversalis. Posterior wall of internal oblique aponeurosis, transverse abdominis aponeurosis and fascia transversalis. And fascia transversalis. And finally, when we go for the section below the arcuate line, now arcuate line is the lower limit of the posterior wall of rectus sheath. If you take a section below the arcuate line, that means there is no posterior abdominal, no posterior wall of rectus sheath. So if you take a section below the arcuate line, this is how it goes. So once again, all the muscles are to be seen. Once again, same scenario, all the muscles can be seen here. Once again, external, this is again external oblique, internal and transverse abdominis. External oblique aponeurosis, again it passes anterior to the, forming the anterior wall, but this time internal oblique and transverse abdominis, the aponeurosis, both these aponeuroses, they will fuse with each other and form the conjoint tendon, which is also forming anterior to it. Forms the conjoint tendon and which is also passing anterior to it. Posterior wall is deficient, all we have again is fascia transversalis. So that is the anterior wall this time. This time the anterior wall once again is by external oblique aponeurosis and conjoint tendon, whereas posterior wall is deficient and we only have fascia transversalis there. Fascia transversalis. This is about the rectus sheath. Finally, the contents of rectus sheath includes, it goes like rule of 2 here, 2 arteries, superior epigastric artery, inferior epigastric artery, 2 set of veins, that is once again superior epigastric vein, and inferior epigastric vein, and 2 types of nerve, I should say, not 2 nerves, that is thoracoabdominal nerve. If you remember thoracoabdominal nerve, guys, we said thoracoabdominal nerves are the one, these are not the typical intercostal nerve, these are the one which are from T7 to T11, supplying the intercostal space as well as the anterior abdominal wall, plus subcostal nerve, and of course is T12. So these are the contents of the rectus sheath, 2 arteries, 2 veins, and you can say 2 types of nerve rather than 2 nerves, that is thoracoabdominal nerve and subcostal nerve. So this is about the anterior abdominal wall. So after this anterior abdominal wall, as I said, we'll talk about the one very important topic here, and that is the perineum. We don't need to know any other thing before we discuss perineum. It's not like that the continuity will be disturbed, so we should discuss the abdomen first. Nothing like that. We can go directly to the perineum, and then we'll discuss the perineum in detail, talking about all those superficial pouches, deep pouches, pelvic diaphragm. Now we people usually find this perineum a slightly difficult topic, so I'll try to make it easy. Now first let me tell you that what is the issue with the perineum, that why, the reason why we don't like this topic much, or why we find this topic bit difficult. See, perineum, the problem is with the orientation actually. We don't see much in the dissection hall in the perineum. When the dissection is done in the lithotomy position, the cadavers are so, they're so stiff that you cannot easily bring them to the lithotomy. So all we do in the perineum is the ischiorectal fossa, nothing much. Secondly, in the perineum, guys, you take any textbook, they start from the superficial to deep. They start with the skin, then they go into Colles fascia, then into superficial perineal pouch, deep perineal pouch, and so on. Now what we will do is we'll start from the deep to superficial. We'll start with the deepest thing, that is the most superior thing, and then we'll go to the superficial part. And because perineum is studied and perineum is all about in lithotomy, so understand one thing, that when you dissect in the lithotomy, whatever is inferior will come first. When you go in the lithotomy, the one which is inferior will come first. As you go superior, it will go later on. So whatever is inferior is superficial, and whatever is deep is superior. Example, if I say superior layer of urogenital diaphragm and inferior layer of urogenital diaphragm, now which one is superficial? Because we are going in from the lithotomy, we are dissecting it from like this, so first the inferior will come. So inferior layer of urogenital diaphragm will be superficial. So inferior is superficial and superior is deep. Just keep it in mind, these two things first, and then we can talk about this perineum here. When you study perineum, guys, never underestimate the boundaries. Don't start reading perineum directly from the perineal pouches or pelvic diaphragm something. First, please understand the boundaries of perineum, because if you don't understand the boundaries of perineum, it will never clear that where exactly the urogenital triangle is and where exactly the anal triangle is, and we'll always find ours in the problem of deciding the lateral boundaries of ischiorectal fossa or the lateral boundaries of pouches. So first and the foremost is the boundaries of perineum. Talk about the perineum here. This is one very important topic. You can almost guarantee a question from this topic. Most frequently asked question from the abdomen is from the perineum only. So as I said, we'll start with the boundaries first. The boundaries. Now if this is the hip bone here, if you're looking at the lithotomy position, this is the hip bone. That is obturator foramen. So this has to be the pubic symphysis. This is pubic bone. This is ischiopubic ramus. Why ischiopubic ramus? Pubis, and this is ischium. This is ischial tuberosity. This weight bearing region, that is ischial tuberosity. This is anterolateral boundary of perineum. Pubic symphysis, pubic bone, ischiopubic ramus, and ischial tuberosity. These are the anterolateral boundary of the perineum. What about the posterolateral boundary, guys? The posterolateral boundary of perineum is by the sacrum and coccyx. This is sacrum here, S for sacrum, and CO for the coccyx, and the ligament which is stretching between the sacrum and the ischial tuberosity. Now what is this ligament here? The ligament here is called as sacrotuberous ligament. It is from the sacrum to the tuberosity, that is sacrotuberous ligament. So this is the first thing, the boundaries of the perineum, that is pubic symphysis, pubic bone, ischiopubic ramus, ischial tuberosity, sacrotuberous ligament, and sacrum and coccyx behind. The first thing is how we divide the perineum. We divide the perineum by an imaginary line passing anterior to the ischial tuberosity, and this imaginary line passing anterior to ischial tuberosity divides the perineum in two triangles here. This is called as urogenital triangle. We have passage of urethra, passage of vagina from here, so it is urogenital triangle. And there we have anal triangle, because we only have opening of anal canal here with external anal sphincter. So the two triangles, under these two headings we will discuss the perineum. One is urogenital triangle and anal triangle. So first of all, let's talk about the structure. If you're drawing, just take a few more seconds and you can just complete this diagram first. Pubic symphysis, pubic bone, ischiopubic ramus, ischial tuberosity, sacrotuberous ligament, sacrum and coccyx. These are all the boundaries. Dividing the perineum is done by this imaginary line passing anterior to ischial tuberosity, and the two triangles in which discuss the perineum is urogenital triangle and anal triangle. So guys, first let's talk about the structure which is separating the pelvis from perineum. See, abdomen and pelvis, they are not separated. I mean, the structures from the abdomen are continuing into the pelvis, but there is a definitive structure which is separating the pelvis above and perineum below, and that diaphragm is called as pelvic diaphragm. So let us talk about pelvic diaphragm. The pelvic diaphragm. Now let's say you don't have to draw the same complicated diagram again and again, so we can just do it like this. This is how the boundaries of perineum are. Guys, pelvic diaphragm, which is separating the pelvis and perineum, is basically a combination of three muscles. There are three muscles which together forms the pelvic diaphragm. The three muscles coming from the three different part of hip bone, and all of them converging toward this bone, that is coccyx, and that's why we call them pubococcygeus, iliococcygeus, and ischiococcygis. Three muscle which coming from the three different part, and all of them converging toward this coccygeus, the coccygeal vertebrae. As I said, these are this is pubococcygeus, this is iliococcygeus, and that is ischiococcygis, which is also referred as simply coccygeus. You can simply call it coccygeus, ischiococcygis or simply coccygeus. Pubo, ilio, and ischiococcygis. Remember, pubococcygeus and iliococcygeus together, these two muscles together are also referred as levator ani. These two muscles together are referred as levator ani. So that's the difference between the levator ani and the pelvic diaphragm. When you say pelvic diaphragm and levator ani, yes, more or less they are the same, but pelvic diaphragm is about pubococcygeus, iliococcygeus, and ischiococcygis. But when you say levator ani, it is only pubo and iliococcygeus. Ischiococcygis or coccygeus is a kind of muscle which has no function as such in human. It is completing the pelvic diaphragm. It's a muscle which is more developed into the animals which have tails, so it is for the movement of the tail. So we don't need it. Now let's say this is a section of female perineum. So there is an opening of urethra, vagina and anal canal. What is the muscle closest to all these three openings? If this is urethra, vagina and anal canal, or I should say rectum actually. So what is the muscle closest to them? That is pubococcygeus. So these are the slings which are formed by the pubococcygeus. That's a modification of pubococcygeus muscle here. You can see the one which are encircling all these openings are nothing but the modification of pubococcygeus, named as this is pubo-urethralis, pubo-vaginalis and puborectalis. Pubo-urethralis, pubo-vaginalis and puborectalis. Remember, these muscles are the modifications of pubococcygeus. These muscles are modifications of pubococcygeus. Pubo-urethralis, pubo-vaginalis and puborectalis. And also remember that puborectalis is the main muscle which is actually maintaining the anorectal angle, and it also is the muscle of continence. It's the muscle of continence. It is a major support of the rectum. It maintains the the anorectal angle, and it is also called as the muscle of continence. This is about the first layer of the perineum, that is pelvic diaphragm, which is made up of three muscles: pubococcygeus, iliococcygeus, ischio-coccygeus. And pubococcygeus being closer to all these openings, it will encircle or surround these openings by its modification called as puborectalis, pubovaginalis and pubourethralis. As we said, this is the first layer. Let's come below the pelvic diaphragm. Now we have to build the pelvic diaphragm and started with the superior layer. We said we'll be starting perineum from above downwards. In the textbook it is given from superficial to deep. We'll go from deep to superficial. So pelvic diaphragm is the first thing. Now remember, the pelvic diaphragm is covered with the fascia above, which is called as pelvic fascia. It faces the pelvis, so we call it pelvic fascia. And the fascia below the pelvic diaphragm toward the perineum is called as anal fascia. Pelvic fascia above, anal fascia below. And you guys know about pelvic fascia better with the name of the ligaments. All these ligaments like transverse ligament of Mackenrod, uterosacral ligament, puboprostatic ligament, what are they? These are nothing but the thickening of pelvic fascia. And what is pelvic fascia? It is a superior fascia of pelvic diaphragm. Inferior fascia of pelvic diaphragm is anal fascia. And even if you come below the anal fascia, then you will find another diaphragm, but that diaphragm is present only in this part here. What triangle is this, guys? This triangle is urogenital triangle. So the diaphragm is also called as urogenital diaphragm. So let us come to the next layer of the perineum. So there we go. Once again, if this is the boundaries here. The triangle we are talking about this time is urogenital triangle, and the diaphragm is urogenital diaphragm. So let's say there is urogenital diaphragm here. This is urogenital diaphragm. Remember, urogenital diaphragm is also double layered. See, first thing was the pelvic diaphragm. Below the pelvic diaphragm, this is double layered urogenital diaphragm, which will have superior layer of urogenital diaphragm, but you are seeing it from lithotomy, so you can only see the inferior layer of urogenital diaphragm. There is pelvic diaphragm, there is superior layer of urogenital diaphragm, and there is inferior layer of urogenital diaphragm. So imagine you are looking at the inferior layer of urogenital diaphragm, and this inferior layer of urogenital diaphragm, this inferior layer of urogenital diaphragm This inferior layer of urogenital diaphragm is also called as perineal membrane. This inferior layer of UGD is also called as the perineal membrane. Below the perineal membrane or below the inferior layer of urogenital diaphragm, let's say this is bulb of penis. If let's consider this a male perineum, so this is bulb of penis, and there we have crus of penis. Bulb and the crus of penis covered with their respective muscles. Bulb and the crus of the penis covered with their respective muscle, that is this is the crus. The muscle on the crus is called as ischiocavernosus because it is coming from the ischium and it will cover the hollow part of the penis, that is caverned part of the penis called as ischiocavernosus. And this muscle, this is here bulb of the penis covered with bulbo, also covering the bulb and the spongy urethra, so bulbospongiosus. Bulbospongiosus. Ischiocavernosus and ischiocavernosus, bulb and bulbospongiosus, along with a superficial muscle present transversely here called as superficial transverse perineal muscle. This is referred as superficial transverse perineal muscle. We'll be calling it STP for now, superficial transverse perineal muscle. So how many layers we are done with till now, guys? Look at the layers including the fascia. The very first thing which separates the pelvis and perineum is what fascia? First we have the pelvic fascia, then we have pelvic diaphragm, then below we have anal fascia, and then we have this urogenital diaphragm with the superior layer of urogenital diaphragm and the inferior layer of urogenital diaphragm. So this is the inferior layer of urogenital diaphragm, and below the inferior layer of urogenital diaphragm in the male perineum, let's say this is bulb, crus, bulbospongiosus, ischiocavernosus, along with the muscle that is superficial transverse perineal muscle. Superficial transverse perineal muscle. Now we already know that all we have in this triangle, anal triangle, is anal canal with the external anal sphincter. That is external anal sphincter. So this point here where all these muscles are converging, this is called as perineal body. This point here, this is referred as perineal body. Perineal body, guys. What is perineal body? Perineal body is a fibromuscular node which is formed by the convergence of 10 muscles. There are 10 muscles which are converging together to form the perineal body. And what are those 10 muscles? Now few of these muscles are paired and few are unpaired. Paired and unpaired muscles to form the perineal body. What are the paired muscles forming perineal body? The paired muscles are, you can see from this picture, the paired muscle R1 is bulbospongiosus, it's a paired muscle, bulbospongiosus. Superficial transverse perineal muscle. Now superficial transverse perineal muscle is below the perineal membrane, that's why we call it superficial transverse. Now there is a muscle which is inside the pelvic diaphragm, urogenital diaphragm, sorry, that is called as deep transverse perineal muscle. So one we have in the paired group is superficial transverse perineal muscle, then we have deep transverse perineal muscle, then we have bulbospongiosus, not ischiocavernosus, ischio is on the side, bulbospongiosus and levator ani. That's the reason why we call it levator ani, because it converges toward the anal canal from both sides. Levator ani. We'll look at this levator ani better in the ischiorectal fossa. So remember, these are the four paired muscle which forms the perineal body: superficial transverse perineal, deep transverse perineal, bulbospongiosus, and levator ani. Unpaired muscles are the one which are present in the midline. We have only two unpaired muscle. One obviously that we can see in that picture is external anal sphincter. External anal sphincter. External anal sphincter is a circular muscle. Now longitudinal muscle of anal canal is also forming the is also contributing to perineal body. So that is longitudinal muscle of anal canal. You can say longitudinal muscle of rectum also, because the same longitudinal muscle of rectum are coming to anal canal. So 4 paired, that makes it 8, and 2 unpaired, that makes it 4. 2 unpaired, that is 2 plus 8 makes it 10. So we have 10 muscles in the perineal body, 4 paired and 2 unpaired muscles. These are the muscles of the perineal body, or the muscles converging to form this fibromuscular node called as perineal body. Let us understand this perineum better in a sagittal section, where we can also talk about the superficial and deep pouches. Zoom out please. So what we'll do is we'll take a section from the perineum from here. We'll take a section like this. We'll take a sagittal section in this manner, and then let's understand this perineum here. So let's take a sagittal section, and so that we can talk about the pouches. Okay. So guys, once you take a sagittal section, see again it is all about orientation. From superficial to deep, what are the structures? When you take a section here, the superficial to deep structures will be, what is the first layer? Well, the very first layer is the superior layer of the pelvic diaphragm. That is, what is the superior fascia of the pelvic diaphragm? That is pelvic fascia. So the very first thing is the pelvic fascia here. Let's say this is pelvic fascia. Below the pelvic fascia is pelvic diaphragm. This is pelvic fascia. This is pelvic diaphragm, and below pelvic diaphragm we have the anal fascia. That is anal fascia. Pelvic fascia above, pelvic diaphragm in between, and then we have anal fascia. This is pelvic diaphragm. You remember that the combination of 3 muscle, that is ilio, ischio, and pubococcygeus. Coming below only into the urogenital triangle. Now we just saw that in the urogenital triangle we have the superior layer and the inferior layer of urogenital diaphragm. So this is the superior layer of urogenital diaphragm. Let's say this is the superior layer of urogenital diaphragm, and below that we have inferior layer of urogenital diaphragm. This is inferior layer of urogenital diaphragm. This is superior layer of UGD, and that is inferior layer of UGD, that is urogenital diaphragm, also called as perineal membrane. So superior layer and the inferior layer of urogenital diaphragm. We took a mid-sagittal section, guys. We took a mid-sagittal section. So will it go from the crus of the penis or the bulb of the penis? It is from the bulb of the penis. So bulb and the shaft. So there we have it. This is the bulb and the shaft. and let's say that's a urethra inside. That is urethra here. Finally, to enclose this from below, now let's see, this is important here. We didn't talk about this part which I am going to do till now. This is all we already talked about. The only thing is we are taking a section of the sagittal. This whole thing is the pelvic diaphragm with its fascia. Then we have the urogenital diaphragm with two layers, superior layer and the inferior layer of urogenital diaphragm. And there we have the bulb and the bulb of the penis, along with the, you can see the spongy urethra running in it. Anterior abdominal wall is having Camper's fascia and Scarpa's fascia. And out of the Camper's and Scarpa's fascia, guys, Scarpa's is a membranous layer. So let's say if this is a Scarpa's fascia of the anterior abdominal wall, this Scarpa's fascia of anterior abdominal wall will continue into the scrotum as Colles fascia, as the Dartos muscle, sorry, and then behind as Colles fascia. So it's the same thing, just the name changes. The name and the modification. This is Scarpa's fascia. The Scarpa's fascia in the scrotum forms the Dartos muscle and fascia, and then in the perineum it continues as Colles fascia. So I am using the same color code, that's the reason, Colles fascia. The Colles fascia which merges with this perineal membrane, or you can say inferior layer of urogenital diaphragm. Superior layer of urogenital diaphragm, inferior layer of urogenital diaphragm, you can see there, and then below now we have this Colles fascia which is continuation of the Dartos muscle. What is Dartos muscle? It's a continuation of, or it's an extension of Scarpa's fascia. Okay, now look at this picture, and now we can talk about the superficial and deep pouches. In this picture, where is the superficial pouch and where is deep pouch, guys? And make sure you label it exactly the way the region I am labeling it. This is deep perineal pouch, and this one is superficial perineal pouch. Perineal pouches, the superficial and deep perineal pouch. Deep perineal pouch is between the two layers of urogenital diaphragm, and superficial perineal pouch is below the inferior layer of urogenital diaphragm, which as I said, which is also called as perineal membrane. Let me also tell you that fusion of the superior layer and inferior layer of urogenital diaphragm, this fusion here, this is called as transverse perineal ligament. This fusion of superior and the inferior layer of UGD is referred as transverse perineal ligament. We also call it transverse perineal ligament. Now, keeping this in mind, keeping this picture in mind, first let's talk about the boundaries of deep perineal pouch and superficial perineal pouch, and then we will talk about the contents of superficial and deep pouches. So starting with the boundaries first. So I'll so I'll stick to this same board only so that we can use the diagram over and over again. So first, boundaries. Boundaries of वो picture साथ में रहना चाहिए. Boundaries of deep perineal pouch. Boundaries of deep perineal pouch first. The boundaries, guys. Now from this picture you can see anterior boundary, posterior boundary, roof and the floor. Roof is by, just keep looking at keep telling it to yourself. Roof is by what? Roof is by the superior layer of UGD. Floor is by what? Floor is by the inferior layer of UGD, which is also called as perineal membrane. You better call it perineal membrane because in questions they usually say perineal membrane, perineal layer or perineal membrane, better term. Anterior wall as you can see is by the fusion of superior and the inferior layer, which is called as transverse perineal ligament. Transverse perineal ligament. And posterior layer, there is no specific name given to it, so it's simply the fusion of, it simply is the fusion of superior and inferior layer of UGD. It simply is the fusion of superior and the inferior layer of urogenital diaphragm. In the sagittal section you can see roof, floor, anterior wall, posterior wall. The question is what is the lateral wall or what is on each side, and there comes the boundaries of the perineum into the picture. Can you just go back to the very first page of the perineum, the very first diagram that you drew in the perineum. The very first thing we discussed in the perineum was the boundaries of perineum. So what is the anterior lateral boundary, guys? If you look at that picture, anterior lateral boundary is by ramus. What ramus? That is ischiopubic ramus. And that ischiopubic ramus is the lateral boundary for superficial pouch as well as deep pouch. So for both deep pouch and the superficial pouch, the lateral boundary will be ischiopubic ramus. Ischiopubic ramus. So this is about the boundaries of deep perineal pouch. Coming to the boundaries of superficial perineal pouch, we'll talk about the content later. First, superficial perineal pouch boundaries. Now look at this picture here. The boundaries of superficial perineal pouch, guys, roof we can see, floor we can see, posterior wall we can see. So let's write down what we can see there. This time the roof is formed by the same thing which is forming the floor for the deep pouch, and that is perineal membrane. Roof is by perineal membrane. Floor is by Colles fascia. Posterior wall, as you can see, posterior wall is by the fusion of Colles fascia and perineal membrane. Fusion of Colles fascia and perineal membrane. Anterior wall of the superficial perineal pouch, very important, is deficient. There is no anterior wall, and that's why the content of superficial pouch or any fluid accumulation in the superficial pouch or extravesical urine in the superficial perineal pouch can come into the scrotum. So anterior wall is deficient. Anterior wall is deficient, and once again the lateral wall is by ischiopubic ramus. Lateral wall again is by ischiopubic ramus. Lateral wall is by the ischiopubic ramus. So this is about the boundaries of the superficial and deep perineal pouch, first thing. And remember, the anterior boundary of the superficial pouch is deficient, so let's talk about that only. Now guys, let's say, before we go to the contents, let's say if there is an injury of urethra in the deep perineal pouch and the injury of urethra in the superficial perineal pouch. So what will be the difference? What is the level of extravasation of urine where the urine will accumulate in? Now, one we are talking about injury here, that is injury of the urethra in deep perineal pouch. What urethra is this? This is membranous urethra, and this is spongy urethra. See, if the injury is in injury to membranous urethra, in case of injury to membranous urethra, urine will accumulate in deep perineal pouch only, and that's all. Deep perineal pouch is closed from every side, anterior wall, posterior wall, roof, floor, lateral wall, everything is there. So if there is injury to the membranous urethra, then the urine will accumulate in deep perineal pouch, and that's all. But if the injury is to spongy urethra in the bulb of penis, then it's a completely different story here. So injury to the spongy urethra in the bulb of penis, that means injury here in the bulb of penis to the spongy urethra. As you can see, obviously first the urine will go into superficial perineal pouch. Anterior wall is deficient, so urine can easily come into the scrotum. Now this dartos muscle is actually continuation of Scarpa's fascia, which is a superficial fascia, and superficial fascia do not have attachment to muscle or bone. So they will, that urine can continue behind the Scarpa's fascia into anterior abdominal wall, and maybe to your surprise, in extreme cases it can even reach till the floor of axilla. And it can also go into the upper part of thigh, because Scarpa's fascia goes into the thigh and merges with the fascia lata. So in that case, guys, urine will accumulate. If the injury is to the spongy urethra in the bulb of penis, urine can accumulate in, number one, superficial perineal pouch, scrotum, anterior abdominal wall till the floor of axilla, anterior abdominal wall till the floor of axilla, and upper part of thigh, till Holden's line, and upper part of thigh till Holden's line. What is Holden's line, guys? What is a Holden's line? Holden's line is a fusion of, it's a fusion of Scarpa's fascia and fascia lata. Holden's line represents the fusion of Scarpa's fascia and fascia lata. If you draw a transverse line from pubic tubercle, that is Holden's line. You take a radiograph, mark a pubic tubercle and draw a transverse line from the pubic tubercle, that represents Holden's line. So Holden's line is represented by a line drawn transversely from pubic tubercle, which represents fusion of Scarpa's fascia and fascia lata. So injury to spongy urethra, the urine can go into the superficial pouch, scrotum, anterior abdominal wall till the floor of axilla, that is extreme cases, and then upper part of thigh till Holden's line. So this is the first thing about the superficial and deep pouch, about the boundaries and about the extravasation of urine in the injury of membranous urethra or injury to the spongy urethra. Now let us talk about the contents of the superficial and deep perineal pouch. So once again we'll stick to the same diagram only, and we'll talk about the contents of superficial pouch and deep pouch. Contents of deep perineal pouch first. Now let me add the contents here first, and then we'll write it down there. The contents of deep perineal pouch, we can already see one content, that is membranous urethra. So I'll just keep looking at it and keep writing it here. So one content is membranous urethra. This membranous urethra is covered with the sphincter, that is external urethral sphincter. external urethral sphincter. See, internal urethral sphincter is close to the neck of the bladder. This is external urethral sphincter, the one which is under voluntary control. And also remember, internal urethral sphincter is absent in females. Please note that. Internally, write it somewhere else, that internal urethral sphincter is absent in females. The function of internal urethral sphincter is to prevent the sperm from going back into the bladder. So females do not have internal urethral sphincter, that is only present in male. External urethral sphincter or sphincter urethrae, that is the content of deep perineal pouch. What else we have? When you saw the lithotomical section, when we are looking at the layers of the perineum, we saw all those muscle, bulbospongiosus, ischiocavernosus, and there was a muscle called a superficial transverse perineal muscle. Guys, superficial transverse perineal muscle is present below the perineal membrane, that's why it is superficial. So in the sagittal section it will be somewhere here, superficial transverse perineal muscle. Similarly, there is a deep transverse perineal muscle which is present above the perineal membrane. So deep transverse perineal muscle is another content here. Superficial transverse perineal, I'm sorry, deep transverse perineal muscle, not superficial, deep transverse perineal muscle. Deep transverse perineal muscle. कितनी बार बोलना पड़ेगा इनको? Apart from the membranous urethra, sphincter urethrae or external urethral sphincter, deep transverse perineal muscle. Now, if this is a section of male perineum here, so we'll have this gland here, that is bulbourethral gland, and the duct of bulbourethral gland which will go and join the spongy urethra. So that gland over there is bulbourethral gland. Bulbourethral gland. Okay. Apart from these structures, the structures which will pierce the perineal membrane. See, the perineal membrane will be pierced by many arteries and many nerves. All those structures which are piercing the perineal membrane, they are all content of superficial and deep pouch both. So I'll just write structures piercing perineal membrane. Structures piercing perineal membrane. Whatever it is, I mean, we have to do MCQs. Forget about what are the structures piercing perineal membrane. Deep artery of the penis, dorsal artery of the penis, dorsal nerve of the penis. We have the artery to the urethra, artery to the bulb of penis, posterior scrotal nerves and vessels. You don't have to remember all these. If it is a nerve or vessel, what that will do, that will go into the deep perineal pouch first, and then it will pierce the perineal membrane to come into superficial pouch. So nerve and vessels, whatever the nerves and vessels are, they are content of superficial pouch as well as deep perineal pouch. So there have been both. So structures piercing perineal membrane, this word is good enough to tell you all the contents. So whenever you find any artery or any nerve or any vein or any vessel in the options, that definitely is not answer to the question, because question is always about what is the structure of the superficial pouch or what is the structure of deep pouch. They never ask what is the common structure in superficial or deep pouch, right? They are specific about what are the structures specifically present in the superficial or in deep pouch. So remember, that is structures piercing perineal membrane. Now, if this is all about the contents of the male perineal pouch, what in case of female? In case of female perineal pouch, the only difference we'll see is we'll still have the urethra will be there will be external urethral sphincter, there will be deep transverse perineal muscle. The only difference will come here. So I'll say that 1 just like that, 2 is like that, I mean not membranous urethra, it's simply urethra here, 3 again same. 4, no bulbourethral gland. There is no gland. In case of female, the gland, that is Bartholin's gland, is not present in the deep perineal pouch, it is present in superficial pouch. So basically no gland in case of female deep perineal pouch. And once again the structures piercing perineal membrane. What you can add here is the passage of vagina. So these are the two things which you have to remember. This is one, that there is no gland, and 2, passage of vagina. Rest everything is same. Rest everything is same. This is about the deep perineal pouch. Coming to superficial perineal pouch. Coming to superficial perineal pouch. The contents of superficial perineal pouch, actually we are already done with the contents of superficial perineal pouch, because everything present below the perineal membrane is the content. Remember when we draw the diagram in which we saw the perineal membrane and we have bulb of penis, then crus of penis covered with their muscle, superficial transverse perineal muscle, all those things which are present below the perineal membrane are content of superficial perineal pouch. So superficial perineal pouch content are bulb and bulbospongiosus, crus and ischiocavernosus, superficial transverse perineal muscle, bulb bulbospongiosus, crus ischiocavernosus, superficial transverse perineal muscle, Bartholin's gland in case of females, as well as passage of vagina, and structures once again piercing perineal membrane. Structures piercing perineal membrane, which I told you don't have to bother about. The structures piercing perineal membrane, whatever nerve, arteries, vessels, whatever are there, they are all in here. So bulb and bulbospongiosus, crus ischiocavernosus, superficial transverse perineal muscle. I've written only bulb and crus, bulb of penis or bulb of vestibule, whatever it is, so you can just judge it for both male and female. Bartholin's gland. These are the kind of thing that you must remember, that the Bartholin's gland, right? This is specific to the superficial pouch. That is bulbourethral gland, specific to the deep perineal pouch. Then bulb of penis and crus of the penis, they are related to the superficial pouch. So the structures which are either present only in superficial or deep perineal pouch, they are more important to remember. So this is about the perineal pouches. One more topic that we need to discuss in the perineum is, this is all about the urogenital triangle. Zoom out please. This is all about the urogenital triangle. So we talked about this pelvic diaphragm here, we talked about this urogenital triangle. Now we need to shift here. We need to talk about in this region, and that is all about the ischiorectal fossa. This whole thing is about the ischiorectal fossa. So let us now talk about the ischiorectal fossa to finish the perineum thing. Ischiorectal fossa. The first thing is that this is a misnomer. Ischiorectal fossa is actually ischioanal fossa. Ischiorectal fossa is actually ischioanal fossa. It's a fossa on the either side of anal canal rather than the fossa around the rectum. So the better word is ischioanal fossa. Now once again I need to draw the boundaries first in the lithotomic section only. If you remember this ligament, that was sacrotuberous ligament. Okay, and there was this perineal membrane, posterior boundary, posterior margin of perineal membrane. So we are talking about ischiorectal fossa, guys. This is anal canal with external anal sphincters. These are the ischiorectal fossa. This is one ischiorectal fossa and there is another, which are communicating to each other behind anal canal. Not anteriorly. Why? Because there is perineal body. So behind the anal canal, both the ischiorectal fossa are communicating to each other. This is anterior boundary, this is posterior boundary, here we have lateral and that is medial. So going with that picture here, this is the anterior boundary, talking about the boundaries. The anterior boundary of the ischiorectal fossa is by the perineal membrane or the posterior margin of perineal membrane. The medial boundary of ischiorectal fossa is by external anal sphincter plus levator ani muscle, which we cannot see in this image. We'll see it in the next one. This levator ani, we'll see it in the next image. Lateral boundary is by a muscle, which again we'll appreciate better in the next coronal section, is a muscle here on the side that is called as obturator internus and its fascia. Lateral boundary is by obturator internus and its fascia. Whereas posterior boundary is by the sacrotuberous ligament and the muscle which is originating from the sacrotuberous ligament, that is the largest muscle, called as gluteus maximus. So posteriorly we have sacrotuberous ligament and gluteus maximus. Sacrotuberous ligament and gluteus maximus. These are the boundaries of the ischiorectal fossa first. That is, perineal membrane forms the anterior boundary, posterior is by the sacrotuberous ligament and gluteus maximus, medially by external anal sphincter along with levator ani, and lateral boundary by obturator internus and its fascia. To understand this ischiorectal fossa properly, we need to take a coronal section. There is one more thing which we'll do in the perineum, that is, we'll take a coronal section from the ischiorectal fossa to appreciate what are the medial and lateral boundary and what are further subdivisions of ischiorectal fossa, to understand its clinical implication as well. So guys, let's take a coronal section for this ischiorectal fossa and try and understand the different part of ischiorectal fossa with this. I hope you're done with this. So let's take a coronal section. In the coronal section, let's say this is the anal canal here. That is skin of the gluteal region, As we said, lateral boundary is by obturator internus and its fascia. So let's say if this is obturator internus here, this is obturator internus, this is external anal sphincter, and then we have levator ani also forming the medial wall. See, this is how why the levator ani is forming the medial wall, because it is sloping like this. As I said, lateral boundary is by the obturator internus and its fascia. And its fascia, that is obturator fascia. Medial wall is by levator ani by external anal sphincter levator ani by external anal sphincter. We know levator ani is covered with a fascia under its surface. See, levator ani is nothing but the part of pelvic diaphragm only. And what was the fascia below the pelvic diaphragm? That was anal fascia. So same thing here. So that is anal fascia. From the Hilton's line, there is another fascia which extends laterally. This is called as perianal fascia. Fascia is very important in ischiorectal fossa. This is called as perianal fascia. Perianal fascia. So we are done with three fascia now: obturator, perianal, and anal fascia. Another fascia which is connecting the anal fascia and obturator fascia, this is called as lunate fascia, guys. This one here, it's moon shaped, so we call it lunate fascia. This is called as lunate fascia. Now, because of all these fascia, the ischiorectal fossa now is divided in three parts. That is this one, and this one. The space that you see below the perianal fascia, this is called as perianal space. To name them, this is called as perianal space. I'll just rub the labeling here. This is number one is name given to the perianal space. Number two is ischiorectal fossa proper, and number three here is suprategmental space. This is called as suprategmental space. Perianal space, ischiorectal fossa proper, and suprategmental space. Now we know the main content of the ischiorectal fossa is fat. So we have fat here, everywhere. Now what is the difference in the arrangement of fat, guys? There is a difference of arrangement of fat in the perianal space and rest of the ischiorectal fossa. The fat in the perianal space, the fat is very tightly loculated. Now because of this tight loculation, there are loads of connective tissue over there, and this is tightly loculated. We have loads of connective tissue present in here, and the fat is present in between these connective tissue. And because fat is very tightly loculated here, infection of this space are very painful. Infections of perianal space are very painful because the fat is tightly loculated in this region. Whereas the fat in the ischiorectal fossa proper and into the suprategmental space is loosely loculated. Comparatively, it is loosely loculated. It is not as tightly loculated as in case of the perineal space. So the infection of ischiorectal fossa proper or suprategmental space are less painful comparatively. Another important thing about ischiorectal fossa here is that because of this lunate fascia, and let me highlight these, because of the lunate fascia, obturator fascia and perineal fascia, these three, not anal, lunate, obturator and these three fascia together forms a canal in the lateral part of ischiorectal fossa. This is called as pudendal canal. This canal here is called as pudendal canal. Please note it somewhere that pudendal canal is found by the modification of lunate, obturator and perianal fascia. Pudendal canal is found by the modification of lunate, obturator and perianal fascia. The three fascia together forms the pudendal canal. The three together forms the pudendal canal. So now I can say the contents of the ischiorectal fossa are, now I can say contents of ischiorectal fossa are, first obviously primarily there is fat, then we have pudendal canal and its content, pudendal canal and its contents. And what are the contents of pudendal canal? We already saw that when we were discussing the gluteal region, that is pudendal nerve, that is S2, S3, S4 and internal pudendal vessels. And internal pudendal vessels, pudendal canal and its content, pudendal, which is pudendal nerve and internal pudendal vessels. Also one more thing, one very important thing guys, and for that I want you to focus here, just focus the camera here. Yes, now for that let me just tell you what exactly I am trying to point out here is, guys, pudendal canal actually, if I have to draw the pudendal canal here, now pay attention to this, pudendal canal is running like this. It is in the lateral part of the ischiorectal fossa. You cannot see it very clearly because it is mostly deep to the sacrotuberous ligament. But what is the purpose of these pudendal canal? One is here, one will be on this side. The purpose of pudendal canal is to give passage to the pudendal nerve to go into the urogenital triangle, because most of the structures are in urogenital triangle. Similarly, it also gives passage to the internal pudendal vessels to go like this. So most of the structures from pudendal canal has to go into the urogenital triangle, but there is something here to be supplied. There is at least anal canal and external anal sphincter to be supplied. That's why a branch of this pudendal nerve will come like this. Similarly, a branch of internal pudendal vessel will also pierce the medial wall of pudendal canal and come out like this. These are the only structures which are running transversely in the ischiorectal fossa, and that's why if there is any abscess of the ischiorectal fossa and you try to drain that abscess by giving an incision, these are the nerves and vessels which can get damaged, and these nerves and vessels are inferior rectal nerves and vessels. Inferior rectal nerves and vessels. The structures which can get damaged by putting an incision in the ischiorectal fossa to drain the abscess is inferior rectal nerves and vessels. Make sure you write it, that the structures which can get injured or damaged by the incision in the ischiorectal fossa to drain the abscess is inferior rectal nerves and vessels. Structures which can get injured or damaged by incising the ischiorectal fossa to drain the abscess are inferior rectal nerves and vessels. So when you write the contents, and when you think about the contents of ischiorectal fossa, it is fat, pudendal canal and its content, and inferior rectal nerves and vessels which are susceptible to the injury. while draining it, the ischiorrectal fossa. And lastly, the recesses of ischiorrectal fossa. The very last thing in the perineum is the recesses of ischiorrectal fossa. There are three recesses, guys. We have an anterior recess. Anterior recess of ischiorrectal fossa. What is anterior recess? See, ischiorrectal fossa can extend anteriorly into the urogenital triangle as well, but it cannot go into superficial pouch, it cannot go into deep pouch, it can go above the urogenital diaphragm. So anterior recess is above, or you can say deep, above is deep to urogenital diaphragm. Anterior extension of ischiorrectal fossa is deep to urogenital diaphragm. Posterior recess of ischiorrectal fossa is this. See, this ischiorrectal fossa can extend anteriorly. This is the urogenital triangle. Anteriorly, it can extend like this, deep to urogenital. That is anterior recess. Posteriorly, it can extend like this, or it extends like this. There is a space above the sacrotuberous ligament, which is called as the posterior recess of the ischiorrectal fossa. So it is deep to sacrotuberous ligament. Deep to sacrotuberous ligament. And then finally we have horseshoe shaped recess. Finally we have this horseshoe shaped recess. What is horseshoe shaped recess? We already talked about this. We said both the ischiorrectal fossa will communicate behind the anal canal. See, anteriorly there is perineal body, but both ischiorrectal fossa can communicate behind the anal canal. So if there is any abscess of this ischiorrectal fossa, that can easily transfer into the another one. And that's why the abscess of ischiorrectal fossa are also called as horseshoe shaped abscess. They will take a shape of the horseshoe, so they are also called as horseshoe shaped abscess. So it is nothing but the communication of both ischiorrectal fossa behind anal canal. Communication of both ischiorrectal fossa behind anal canal. Behind anal canal. So guys, this is about the perineum. Now let's take a lunch break here, and we'll meet after the lunch break, and we'll continue with the rest of the abdomen. We'll discuss about the peritoneum, the blood vessels of the GIT. We'll take some important viscera as well, and then the last session will go about the general histology and the general anatomy part. So till then, we'll catch you back in after the lunch.